coming? Yeah.
Yes, sir.
Okay, so a brief talk on chest radiographs. When looking at a chest radiograph, there are multiple radiographic densities, as we call them, starting from what appears the whitest on a radiograph or an X-ray is metal, down to bone, followed by soft tissue and solid organs, and fat, as you can see pointed out here. You also have fat in the body wall, and finally air, which is in the lung. Now, air in the lung is always going to be a little lighter or less black than air outside that you may see if those areas are included in the radiograph given to you. Now, when commonly acquiring a radiograph, one uses a PA view. This is a postero-anterior view as seen in this image. The X-ray enters from the back of the patient and passes out from the anterior aspect of the chest to fall onto the cassette that you see here. Now, the patient is always upright, faces the cassette with his chin up or her chin up. The shoulders are rotated forward and an exposure is made on full inspiration. By contrast, an AP view radiograph is obtained with the patient's back to the cassette. The upper edges of the cassette lie above the lung apices, and here again we make an attempt to rotate the shoulders anteriorly, but they end up being lateral, as you can see on this image here. So now you will notice that the distance from the source of the X-rays to the patient is much shorter in a antero-posterior radiograph. Also, the cassette lies behind the patient. Same patient, two different radiographs. This is a PA view and this is an AP view. You will note that the lungs are very well seen on this. The cardia appears as it normally should, as opposed to the antero-posterior view, where the lung fields are a little hazier and also the cardia appears apparently enlarged. So we'd assume that the distance from the film, that is the cassette, to the source is much shorter here and is much larger in a PA view. A few technical aspects to consider when assessing a radiograph or an X-ray are firstly the centering of the radiograph. The medial aspects of the clavicle should be at an equal distance from a line drawn through the spinous processes. So if this was one spinous process joined all the way through to the others, the medial ends should be at equal distances. When you say a radiograph has been obtained with an adequate inspiratory effort, when you have at least 5 to 7 anterior ribs. So if you would count these anteriorly, these are the anterior ribs, and the posterior ribs are more horizontal. Since this is a superimposed image, you can't really tell which is anterior, posterior. You have to go by the anatomical knowledge of each rib. When you have 7 to 8 posterior ribs, this also deems the X-ray to be taken in adequate inspiration. When there are less than 4 anterior ribs visualized, you get a poor inspiratory film. Some call it an expiratory radiograph. A little more in detail about the anatomy. Starting from the center at the top of the radiograph, you have your trachea, which is a radiolucent or a dark appearing structure right in the midline. This moves with rotation. The superior vena cava, the pulmonary artery, the right atrium have all been outlined here on the right side, as has the dome of the diaphragm been, which overlies the homogeneous opacity, which is the liver. On the other side is a lucency under the left hemidiaphragm, which is the fundic gas bubble or the gas shadow. The left ventricle and the apex of the heart are seen, as is the left hilum and pulmonary artery, the aortic notch, and as we go laterally into the skeletal structures, both the clavicles, both the scapulae, all the ribs on each side, and the angles, the costophrenic angles and the cardiophrenic angles, which should always be sharp. There is a format that we use to assess a radiograph, which is something like an A, B, C, D, E. So each letter denotes something, air being the airway or the trachea. When the trachea is seen, it should be in the midline. It should slightly deviate a little to the right in its inferior aspect, as it lies in continuity with the right main bronchus. When the trachea is deviated, you can either have a pushed trachea, which is because of a pleural effusion, or a pneumothorax, something causing a mass effect on the trachea, versus pulled trachea, which is because of volume loss on the side pulling it, which is fibrosis or something like a collapse. B stands for bones, and you would check for fractures, dislocations, subluxations, or any form of lesion in the visualized bones. So the clavicles, the scapulae, and sometimes even the ribs and the vertebral bodies. In the same breath, look at the soft tissue overlying these structures, and you might get some important information from there as well. When looking at the cardia, you will assess for size and whether all the borders are sharp or blunted and whether they are well seen or not. You will also look at the cardiothoracic ratio, which should be more than zero point 0.5 in adults, and some even say zero point 0.6 in children in a good quality film. So, in a good inspiratory exposure taken in a postero-anterior fashion. The diaphragm should be well demarcated on both sides. The right is always higher than the left. And you will look for the costophrenic angles to rule out any air under the diaphragm. Follow the silhouette of the diaphragm and you will see if there are loosened areas under this dashed white line. When looking at costophrenic angles, when they are blunted, if blunting is present or there is an opacity in the costophrenic angles, it would indicate that there is an effusion. This, of course, is very evident when the patient is in an erect posture. So a postero-anterior radiograph denotes that the X-ray has been taken in a standing position, and that would mean that there would be dependent layering of fluid in the costophrenic angle. So that becomes an effusion. The lung fields have to be looked for. Check if there are any opacities, is there any collapse, are there air bronchograms, and pay special attention to the apices and other hidden areas of the lung. So when assessing each lung field, you will compare one field with the other and proceed either in a craniocaudal fashion or a caudocranial fashion. Whatever suits you, look at each lung and the opposite side in the same breath. Look for symmetry, look for any other lesions in both the lungs. For descriptive purposes, you have three zones. Now, the upper zone of the lung is above the anterior end of the second rib. So, this is the anterior portion of the rib. This is rib 1. This is rib 2, a line passing through the anterior part of the second rib. This becomes the upper zone on both sides. The middle zone is between the anterior, a line joining the anterior end of the second rib and the anterior end of the fourth rib. So, if this was rib number 2, this is 3, this is 4. This is a line joining, or rather passing through the anterior end of the fourth rib. The space between these two becomes the middle or mid zone, and anything below that becomes the lower zone. These zones do not correspond to anatomical lobes in the lung because the right lung has three lobes, the left has only two lobes, but you will have three zones on each side, the upper, the mid, and the lower zone. A few multiple choice questions. You've been asked to identify the structure indicated by the arrow. Is this the inferior pulmonary vein? Is this a collapsed segment of the right middle lobe, which is appearing as an opacity? Is this the descending pulmonary artery? Or is this a paracardiac pneumonia? So, bringing back this annotated X-ray, you have a structure which resembles the structure seen in the MCQ, and this becomes the descending pulmonary artery on the right side. The marker has also been provided, so look for that. This is the right side, this is the left side. The heart points to the left. This becomes the inferior pulmonary artery on the right side, or the descending pulmonary artery. This radiograph has been given to you. You've been asked to identify the pathology. You may occasionally get a history that this patient has been a smoker, has chronic cough. Is this bronchiectasis, pneumothorax, a hyperinflated lung, or tracheal shift? So look carefully. This is hyperinflation, which is secondary to COPD. You'll notice that the lungs are inflated way more than 5 to 7 anterior ribs and 7 to 8 posterior ribs. Also, the diaphragm has lost its normal hemidiaphragmatic contour. It has become a flat structure on both the sides, and this would indicate a hyperinflated lung. In this X-ray, you've been asked again to identify the pathology. Has there been a left pneumonectomy or has the left lung been removed? Is there a tension pneumothorax? Is there a right-sided pneumonitis? Or is there enlargement of the left atrial appendage? You will notice that the left hemithorax is much darker or blacker than the right side. There is a collapsed opaque structure indicated by the arrowheads, which is the collapsed right lung. The trachea has been shifted to the opposite side, which is the right side. The left side is involved here. The cardiac border, the right heart border, has also been shifted to the opposite side. You see the vertebral column is here, and the heart is way beyond that on the right side. And the diaphragm has been flattened a little bit on the affected side. So this is a tension pneumothorax. In this X-ray, you've been asked to name the sign depicted in the image. You may get a history of fever, of cough, of chest pain. Your options are an air bronchogram, silhouette sign, a cervicothoracic sign, or an air crescent sign. So here, this is an air bronchogram. You will notice that because of the opaque opaque pathology or the opacity in the lung, the air that is left in the traversing airways, the segmental and subsegmental airways, gives this contrasted appearance of a dark branching linear structure within a whiter or a more opaque structure. So this becomes an air bronchogram. And if you get this history of fever, cough, if there is an effusion, this becomes a because of a pneumonia. So there is residual air in the segmental vessels, segmental airways. Here you've been asked which of the following structures can the disease demonstrated be localized to? So two steps in the question. One, identify what the disease is, and two, tell us what the pathology, sorry, identify what the pathology is, and two, tell us what structure has been involved. So here you're looking at the esophagus, the heart, the pleura, or the pericardium. If you were to look at this has a diffusely globose or a enlarged appearance to the heart. This resembles a leather water bottle of old. All right. So this is a pericardial effusion. That is the diagnosis, which localizes the disease to the pericardium, and that gives this leather water bottle sign. If you notice, by contrast, yeah, you would have a down and outwardly shifted heart in pure cardiomegaly or a left ventricular configuration. This globose kind of appearance or this water bottle, leather water bottle kind of appearance may not be present. Here, a patient is presented with hemoptysis and a history of previous pulmonary cox or tuberculosis. Identify the pathology. Is there a right lower zone pneumonia? Is there a left mid zone cavity? Is there hyperinflation of the left upper lobe, or is there a consolidation in the left lower lobe? So here you will notice that there is a cavitatory structure, a loosened structure with an air fluid level. The air is above, the fluid is below, and this is a left mid-zone cavity. So you can automatically rule out two options because it says left upper lobe, left lower lobe. Lobe is not usually a um, term that we use as a descriptive for the radiographic appearance of the chest. You would prefer something that has zone in it. And also the pathology is not necessarily located to that area. The pathology is here in the mid zone and somewhat in the lower zone, and this is a cavity. Thank you.
Yes, doctor. So just